All right. Well, good afternoon, everyone. Thanks for joining us for IPHA's third Thursday Lunch and Learn series. My name is Jenna Heyer, and I am a member of the IPHA Education Committee. This session is being recorded, so you'll see that, and we will post it for anyone who is not able to attend on our IPHA YouTube channel as well. Feel free to mute yourself if you aren't already muted. And you can also put your questions in the chat. Betty ideally would like this presentation to be interactive though, so don't feel like you need to wait until the end of the session. You are welcome to raise your hand or put a question in the chat and we can kind of have dialogue and discussion as we go. There will be plenty of time, I anticipate, at the end for us to have more Q&A though, if that's necessary. So you can turn on your camera then and ask questions as you'd like. So like I said, we are joined today by Betty Mallen, and she is going to speak with us regarding age-friendly healthcare and what that looks like in a community setting like public health. So I'm going to let Betty introduce herself, and we'll see you after for the Q&A.
All right, well, good afternoon, everybody. Thank you for joining this session. As Jenna said, my name is Betty Mallen. I have been a registered nurse for a long time. I got my bachelor's from the University of Iowa in 2005, went on and got a master's in clinical nurse leadership in 2019, and am anticipating in May that I will be graduating from the University of Iowa DNP Health Systems program. My nursing career spanned a lot of different areas, but my area that I fell in love with was public health. And I spent 2.5 decades in local public health in Northern Iowa where I live. So I have an idea of some of the challenges that public health faces, but it still, to me, is an area that we have a lot of potential for what we can offer. I want to talk a little bit about age-friendly healthcare and public health. I am not coming to you as the end-all expert on this topic. And as Jenna said, I would like it to be as dialogue-friendly as it can be. I would love to hear if you are doing initiatives around age-friendly healthcare, what you're doing and how that's working out. I'm going to put a little shameless plug in for the public health conference in March. I will be speaking at that, sharing about my DNP project in a local public health agency. I'm not going to talk about that today, but hopefully this will pique your interest. And if you haven't looked into some of the information that's available on age-friendly healthcare and public health, I'm hoping that you will. So with that being said, I will get started here. I'll see if I can get my slides to move. Yes, it worked. So this is, I'm just really curious, and I can't see all of your responses, but I'm really curious to know how many of you have really heard of this terminology in relation to public health. You can, if you're comfortable with your reactions, put your reactions up. You can raise your hand. You can drop it in the chat. I'm just kind of looking here if anybody's raising their hand, if they've heard of age-friendly. Okay, I see a couple people. All right, awesome. Oh, there's another one. Okay, so a few people that have heard of age-friendly healthcare. How about, have you heard of any initiatives, any of you, in your areas in acute, long-term, or clinic care? And again, just raise your hand if you've heard of any of this going on in, okay, I see a few again.
Betty,
Awesome.
can you see the chat? There's a few in the chat that have said they've heard of it. One person
Okay,
did say
so
they're new, so they have not. So.
And Chris, I'm right there with you. Every year older I get, the more interested I am in who's going to take care of me at some point. So why do we care about this? Why is this even a topic that we talk about? And I know as public health people, you are very data driven. I remember looking at data and thinking about how do we impact this data? I think all of us, if we look at our local data, we see we're getting older. You know, every one of us sitting here knows every day we're another day older. But if you look at the data locally, nationally, even globally, the 65-year and older age group is growing at a faster rate than any other age group. And I believe the 85 plus age group is growing faster as well. When we think about that age group, we know that many of those in that age group will have at least one chronic disease. They may develop chronic disease in those years. There's just different unique health needs of the older adults. And we've not been very good as a health system at anticipating what are those needs going to be and who's going to take care of them. Sorry, I got to do my slides. So when we talk about age-friendly healthcare, and I don't know if any of you are familiar with the work that the John H. Hartford Foundation has done around age-friendly healthcare in public health. I'm assuming most of you have heard of the John H. Hartford Foundation because they are pretty integral in public health topics and public health funding. But in 2017, they convened a meeting in Florida with different public health people who were very interested in this topic, looking at what's the future for public health. How are we going to address this aging population as a nation? And what sort of things do we need to be thinking about? Well, they came up with that public health really has a role to play. We know that in public health, we're about promoting health, preventing injury, managing chronic disease. When you talk about an aging population, those are very, very big topics for them. Optimizing physical, cognitive, and mental health. I'm sure all of you are engaged in several initiatives around that. And then facilitating social engagement. They saw these things as what public health could play a role in. What they also found as they did this, I don't know what you would call it, a think tank or looking at all of this, that it's really rare to have dedicated funding to develop initiatives targeting older adults. And I'm sure if I asked all of you to raise your hand, you would say, yes, that is true. I know in public health, it's hard to get anything funded a lot of times, and it is really hard to get things for that specific population. As this group looked at what's the role of public health, they tagged into this national prevention strategy. And again, I don't know how many of you have looked at this. In public health, we're all about prevention. I bring this up just because I hope that you go and look at these resources. If you haven't, or if you have, but you haven't looked at them for a while, go in and look at them because there's some really good information that I think could inform public health practice around age-friendly healthcare. In the National Prevention Strategy, there's these 7 areas that they look at, and I don't think I need to read them to you. But I also know from my experience in public health, these were the very things that we were focusing on, that we were looking at. How do we impact these things? And if you look at the list of this, again, many of these fit with an aging population. How are we going to address these with an aging population? One of the main goals of the National Prevention Strategy is to increase the number of Americans that are healthy at every age. And again, as we think about 65 plus, and if we were sitting in a room together, it would be easier to dialogue. But I would guess that if I asked you to think about the first thing when you thought of older adults, typically we think about they're not very healthy. That's one of the first things that comes up. And so this is a strategy to help, make it that everybody can be healthy at every age. Within this national prevention strategy, it also encourages a multi-sector collaboration. And I know from my years in public health, we talked about collaboration all the time. We looked at how do we better work with all of the partners that we have. And so this was also something that this John H. Hartford, when they looked at this, they looked at this national prevention strategy. So as we look at age-friendly healthcare, it's difficult to identify exactly who are considered older adults. And I can tell you from working on my DNP project, figuring out who are you going to target as an older adult. If you look at the different groups, and I've just listed a few here, but you have to think about what's their motive or what's their reasoning. So if you look at AARP, they really identify older adults as 55 plus. Well, if you think about, they want more members, that gives them bigger clout as lobbying or influencing public policy. So they define it as 55 plus. Independent living communities define older adults as 55 plus. When you look at the agencies on aging that we have around the state, many of their programs are 60 years old is where they start as an older adult. And then we get Medicare, which is 65 plus. And I bring this up because sometimes it's hard to know what's the target population, and funding sources look at older adult targets differently. So just be aware of that, and probably many of you are aware of that, but there are differences in what defines an older adult. So I want to stop for just a second here. Is there any questions or comments? I see a couple things in the chat, but I don't know.
Yeah, it looks like Chris was agreeing with you, Betty, that there's a lot we think about initially when it comes to the health of older adults. And he brought up a good point about their mental health and disease management and empowerment too. So
yes, and we're going to talk I'm going to talk a little bit about that as we get into what this age-friendly public health, what they said should be the other thing we know about older adults now are they are more ethnically and racially diverse. And that sometimes in Iowa, we are not, there's pockets where we're ethnically and racially diverse, but I can tell you where I live, we're not very racially diverse, but it's still is something we need to consider. And we need to consider what are the inequities in healthcare for this population that already, because of ethnicity or race, are maybe already experiencing inequities. There's also wide variations in social and economic well-being. And we know this is in research, the longer people live, the better the chance that they may end up at some point living in poverty just because of, things that happen as they age and just needing the money to be able to live into a long life. So these are things to consider especially when you're looking at your own data around age-friendly healthcare. You want to look at, how many people you have, but what are the other issues that are going on in your area that may impact what sort of care or what sort of programming you want to get in with this age group. The next thing that this group looked at is what are the needs of an aging society? And this is important, I think, for all of us to think about. One of the top things, and this is on the mind, I think, of anyone who probably gets into Medicare age and older, is am I going to need long-term care or in-home care? And I don't know how much contact all of you have with acute care facilities, but I know in our area, being able to transfer someone out of an acute hospitalization into a long-term care facility can be really tough. I don't think it's lack of beds, but there's lack of staff. It's lack of, how the funding sources, how do we make this work? In-home care, sometimes there's just not that opportunity where the person lives, but it is a real need of an aging society, which we have to think about in public health. What are ways we can address this or help people, figure out what they're going to do? With an aging society, at some point they may need to have a caregiver, maybe not, but most people as they age need someone to kind of walk alongside them and help them with some of the decision making they have to do. Traditionally, that's been family, but I think all of us know how that has changed. Parents and children live longer distances apart, which makes it hard for families to take on that role. Also know that caregiver burnout is a big problem. And how do we deal with that? How do we build that trust in this age group to say that we can help with this? We need to rethink about who can and should be caregivers. Infrastructure of living spaces, as people get older, mobility changes. And so we need to be thinking about built environments, and that's a huge piece in public health. And I think this last one is really big, and that gets to the point, I can't remember who put it in the chat, of mental health and of feeling useful. An aging society, they need to feel they're making a positive impact on the community they live in, and they have a lot to offer. A lot of, as they get older, they're retired, they have the time to put into some of the programs and the things that maybe we struggle to staff or we struggle to be able to offer. I don't know how many of you have seen the World Health Organization Age-Friendly Communities. And I put this in here just because it helps to bring in that bigger picture. We've talked a little bit about, what are some of the needs of an aging society. I also think it helps us realize globally, people are looking at this. Globally, it's an issue. And I know all of these things in this flower are things that, as public health, we look at all of these things, and we're part in that. And I think we need to play a bigger role in that and do the collaborations to make some of this stuff happen. But it's just kind of a nice little way of looking at, okay, how do we start to look at age-friendly healthcare, age-friendly communities? Sorry, my slides, it's hard to get them to advance. There we go. All right, so now I want to get to what came out of this group. So they looked at the different things that were happening. They looked at what are the needs of an aging population, who's looking at this, what sort of things are people proposing that healthcare entities should be doing. So they have 5 potential roles for public health and age-friendly care. None of these are earth-shattering or, rocket science. They're pretty basic ideas, but I think it's good sometimes to just step back and think about who are we as a public health agency and what really is our goal and what do we want to be in our community. And I think some of these will give you a framework to say, yes, this is a place we could connect in and really make a difference. The first one that they identified was connecting and convening multiple sectors and professions that provide the support, services, and infrastructure to promote healthy aging. Again, that's not a new concept for public health. I believe that we always have been that entity that tries to connect the different sectors, the different professions. But to really see it in writing, to say, yes, when we're looking at age-friendly healthcare, it has got to be a multi-sector, multi-pronged approach where everybody's got to get out of their little silo of care. And we've got to start looking at who do we connect with and how do we connect with them. Some of the things that they suggested that we need to start looking at is the physical activity of people, social isolation, which is huge. And I think that was brought up in the chat. And then some of the ways that they suggested public health can be involved in connecting and convening these sectors is our focus on prevention. And if you think about that, in terms of built environment, in terms of managing disease, all of those things we talk about in public health. Policy is big for public health because you just know that, yes, there's a lot we can do on an individual level, at the local level, maybe at the state level, but things that are policy driven can really make a difference. Looking at the systems, you know, how do we get involved in the system change? Because we need to change our healthcare system. And it's hard and it's a big process, but I think public health has a big role to play and we need to step in and start to do that. And then the environmental changes that need to happen to really, let's start looking at what are people doing? How are we addressing what our older adults need in our communities and in our county? Second thing that they looked at was the coordinating of existing supports and services. We want to get rid of the duplication, identify gaps, and increase access to services and supports. This is a big one. And it's a hard one. I can tell you from doing my DNP project, just looking in the county that I live in, it is really hard to know who's doing what for who and when, and you know, where does their service end and this one start and who's eligible. But I think that is a really good first step in seeing how are we going to provide the services that the older adults in our communities need. Identifying the gaps. You know, we can find or provide the needed services. We can find who can offer the service and do that. I think seeing the big picture of service provision in your area, because it's very easy to get in our own little silo and only see what we do and maybe a few of our partners. But if you can get to that next level and see who can be the partners, you know, talking about the last one, you know, who do we connect with? Who do we collaborate with? And then just creative thinking on how to get services to people. We talk so much about patient-centered care. And I'll try not to go too deep in my own soapbox about what I think about patient-centered care, but I would say that 99% of care we get is not patient-centered. The hours that are set up in acute care are not conducive to most people's schedules. How we get service is not very patient-centered. And I think if public health can start thinking about what does it really mean to be patient-centered, and some of that is going to be discovering what do people need and want, and then how do we get the services to them. When I was in public health, we talked a lot about if we're sitting in our office waiting for people to come in, that's not going to happen. What do we have to do to get out to people? And we did a lot of service out in, you know, we went to the schools, we went to senior centers, we went to service groups, we went to businesses, we went out to people. And I think that's a concept that other healthcare systems don't think about. It's people have to come to us. So I really challenge you, be creative when you identify a gap. How can you fill that? And maybe it's not your agency that can do it, but you might be the conduit for somebody else to be able to do it. This next one is everybody's favorite, community health needs assessment. But this is really an important area that public health can make a difference, because we all do community health needs assessments, and we need to start looking at what are the inequities of this aging population and what interventions can we develop. including multiple sectors in community health needs assessment. And I'm guessing most of you do, but even trying to think about who are some really non-traditional partners that we could get sitting at the table to inform this. And that may look different in every community because there's all different kinds of services that are provided depending, when you're in rural areas, it's a little bit different than when you're in an urban area. But starting to understand not just who are the healthcare people, but who are the different people that we can get involved in these community health needs assessments to really figure out how to impact care. Coordinating with other entities. And I know that since the Affordable Care Act, hospitals have to do community health needs assessment. So hopefully, if you're not a hospital-based public health agency, hopefully you have connected with, if you have a hospital in your county or in your community, you're connecting with them to say, okay, what are you doing for community health needs assessment? Because we really don't need two done on the same population. You may have different ideas, but that's what's great. That's what will get the best, especially for this population. If you haven't started collecting your own data on your older population, do that. There's a SHAPE survey. You can Google that. That is, something you can use. There's also, I know, some public health agencies that their environmental health is collecting geographic data to identify areas of need. So they're looking at their whole county, maybe by zip code and by different ways to identify where are the lowest socioeconomic, where, what sort of needs based on where people are living. I can tell you again, where I live, Mason City is the biggest city in our area. And sometimes services, there'll be grants that'll cover the whole region, which can be, counties that are 60 miles away. That really doesn't help somebody living 50 miles away from Mason City to say we have this service here. A lot of them don't have transportation. Some of our smaller rural communities don't even have grocery stores. They don't have the basic needs. And I think we need to start collecting that if we can't find it, to figure out what are the needs of this population and how are we going to meet those. Another area that they thought was important for public health was to conduct, communicate, and disseminate research findings and areas of practice to support healthy aging. We do need to be able to communicate better the things that we do in public health. All of the initiatives that we do, how are they impacting our communities? And now if we start looking at this age group, and we start to do initiatives or we start to look at that to make sure that we're recording that so we can share it with others. That's so important because again, we don't need to duplicate what each of us is doing, but if we can collaborate together and look at the different things we're doing, how much difference would that make with all of us working together? CDC has a Healthy Brain Initiative for aging adults. This is a role for public health in helping to maintain and improve cognitive function. Maybe some of you are involved in this already. Public health can be the repository and the distributor of best practice for older adults. We see all age groups. We see people in different ways than what traditional health systems see. We a lot of times see where they live and the sort of challenges they have. When they go into the acute care health system, they only see and hear what people tell them. We actually see what's going on and we know the communities our people live in. So who better than to do some of this and disseminate some of what we have discovered. And then the last area that they talk about or role is just complementing and supplementing existing supports and services, you know, especially in terms of integrating clinical and population health approaches. I always find it interesting. I worked in local public health for a long time, and then I had an opportunity to go into the clinic critical access hospital setting, and I was a population health manager and a health coach. And it was just interesting to me that population health has kind of become this new term and new way of thinking. And I remember telling colleagues, I can now do a lot of things I wanted to do in public health. I couldn't because I didn't have some of the provider support, some of the funding support. So it's just interesting to me that they've kind of relabeled it, but a lot of what population health does is so integrated with what public health has been doing forever. And I think all of you have probably seen this too probably in the last 5 or 6 years. I hear so much about the social determinants of health, you know, like this is a new concept. And I think public health has talked about the social determinants of health for decades. So it's good that this is getting brought out, but I still think we can be the leaders in really showing how do population health approaches work. One of the ways I have seen in my area is they call them community health workers. And I know there's some public health agencies that employ these as well. These are used in the clinic setting where I am. And what they have done is they are now starting to collect data on the social determinants of health of any patient that comes into the clinic. And that's great. I'm not sure what they do with that information. They're collecting it, so hopefully they're sharing it. But just know that community health workers, I've seen other grants that have these written in. You can have community health workers. I think the whole apprenticeship program that we have in the state of Iowa, community health workers are a big part of that. And in this study that they did, the John H. Hartford, they did see that public health has recognized the benefit of these workers. And I don't know if any of you have them, but if you do, share those findings, you know, collaborate and tell other people what's going on. And then just, you know, complement the existing caregiver resources. We talked about that's a big issue. And I've heard that from agencies on aging, that one of the main questions they get is about caregiver burnout, respite care, those sort of things. And so if there's a way that we can complement that and help find those resources, what a great way to fit in better in our communities and really show what we're all about. So that's really the age-friendly public health framework. I'd like to give a little bit of time here. I'd love to hear what all of you think. You agree with this? You're doing this stuff? This is brand new. You know, what do you think? This was developed for public health by public health people. So I'd love to hear any comments. Has anybody looked at this document? Have you seen it? Got a quiet group here today.
We don't have much in the chat. I
Oh,
will say, Becky,
I
I
see
think,
one here.
oh, here we go. Community health workers. So Kelly said we had an existing staff member get trained as a community health worker, but haven't found a way to bill for that service. So we haven't been using her very much in that role.
Kelly, you bring up a really good point. And I've heard this from other public health agencies too, is even like utilizing nurse practitioners, depending on, you know, how your public health agency is set up, being recognized as a healthcare entity that can bill is hard. And I think that's something when we talk about the policy, we really need to be advocating for those policies that say, hey, we have to have billable codes for these different types of healthcare workers that can work in public health. Because again, we just see people in a different setting than what acute care or the clinic sees. And recognizing that, I agree, is a way that we really need to be thinking about that. Looks like somebody else put in the chat. Okay, Jamie, so yeah, Chris, I agree with you. The siloed lack of funding. So I'm going to move on to my last slide because maybe that will, I think it's my last slide. Yeah, conclusions usually is your last slide. So these are some of my personal, some of what John H. Hartford says. You know, just having done a DNP project in public health about age-friendly healthcare, I've learned a lot and it's been good. But there is great value in pursuing and understanding age-friendly healthcare. And I will tell you that this terminology is going to be continued to be rolled out. There's lots of initiatives in acute care and clinic and a little bit in long-term care around age-friendly healthcare. I believe public health has a role to play. I think we have a big role to play. Again, we see people and we are involved in our communities in ways that our other healthcare entities are not. I think we all know that there isn't any entity that can provide everything that's needed. And being creative in how we collaborate, sharing, you know, how we're using staff, how we're, you know, gaining funding, how we're getting people involved, that's all, you know, we need to be doing. I think we can be that conduit for filling gaps and reducing duplication because again, we see the big picture. I think for everybody, I know that when I was in public health, it's like, okay, I want to do 100 things, but even just choosing one area, you know, pick one of these 5 pieces of this framework and say, hey, this is one that we're going to work on, or maybe you're already working on it and you can expand it. You know, figure out how do you work with your partners and other public health agencies, community agencies, to meet the needs of this older population. And I know during my DNP project, I had the opportunity to attend some aging coalition meetings. I had an opportunity to talk with the head of the population health department at a larger hospital. And it's like there's opportunity out here. It's just figuring out how do we do this and how do we plug into what's already happening. And I think, you know, there's lots of ways to do that. And I would love to hear now just some initial thoughts about when you look at this stuff, what are some things that are happening that you feel like you can get involved in? And Chris, you've had your hand up, so if you want to unmute and speak, love to hear your thoughts.
Thanks, Betty. Hi, yeah, I thought I would come on camera and talk, so I wasn't.
That's always nice.
My fingers were getting tired of typing, so no, this is really helpful. Thank you. And you know, one of the things I was particularly interested about was, you know, you're talking about you know, collaborating and coordinating with other existing organizations who might have see themselves as having a role in this or already having a role in this, right? And so I was curious about, you know, it's like the Aging Coalition, you know, the other nonprofit spaces, but I also wonder about like, you know, some of the private sector folks who might, you know, have a lot of interaction and face time and support already with aging people. So, people like visiting nurses and, in-home care providers, have they been in some of the conversations that you've been a part of? And are there ways that might be an interesting new way of partnering with some private sector partners versus kind of the folks we always go to?
Great point and great question. And yes, I think we have to stop looking just at our traditional partners and start expanding out. I think one area is working with the business sector, because they traditionally have, obviously they have an interest in the community they live in. Some of, depending on how we define older adults, might still be in their workforce. And so there are some great ways. And when I was at Public Health, I was able to work with a manufacturing business and did their workplace wellness. And that was a great partnership. I mean, yes, they probably had a younger population, but there was an older adult population there. And I know that this business, if I would have went to them and said, hey, you know what? I think we should do this for the older adults, even in our community, I know they would have been on board, because they have a vested interest. And that's a great point. I think you need to find who outside of healthcare, because ultimately everybody's interested in healthcare. Because if people are sick, they aren't going to be able to do anything. We have to get into that prevention mode, and how do we keep people healthy and functioning at a high level? So yes, I think look at your business partners, because sometimes they have some pockets of money that, all they can do is say no if you ask. And once you get them thinking in that way, maybe the second time you go, it'll be a yes. We do that in our community. Does that answer your question? Or do you have what other thoughts do you have?
Yeah, no, that's great. Thank you. I was thinking when you were talking about, working with employers and communities too, even if they don't have, if they have difficulty making that jump from, current employees to past employees, or just general, community responsibility, thinking about most of your employees have aging people in their lives too, right? And so how could the company maybe help or provide resources for their employees that could be intermediaries, right? And connect them with some available resources as well, could be really helpful. So just a thought.
And I think that's a key to making sure you're collecting some data on your populations, because if you can see that, 60% of our workforce has aging parents, that's a great stat to take to your business and say, hey, how can we work to support the people who need to support their, the aging adults in their lives? So I think that creativity has to come into play, because we have a system that needs to be fixed, but boy, it's a monster to fix. And I think we're just going to have to keep plugging away every little bit. That's how it's going to happen. Sometimes it's overwhelming, and sometimes I look at it and think there's just no way we're going to change it. But then I think, yeah, we can. Each one of us doing one little thing, we can change it. But thanks for your comments. Anybody else have thoughts or?
Well, Chris's thought made me think of how we have partnered with the business community for a different topic related to childcare. But when you mentioned that, Betty, about business sector and reaching, whether it be manufacturers, whoever, one thing I wanted to throw out was we've had a lot of success in working through our chamber, because businesses have a different language than us in public health and have different values. We found that, as we collaborate with our chamber was really able to garner the business community's support. So that could be one way that people find success in reaching that business community. But I agree, Betty. I think it's so hard because system change. I just feel like we need a roadmap, you know, even of how we get less siloed. Like I need short action-based steps of how we do that. And that's not going to look the same in every community either.
Yeah, it's, again, I also think public health agencies, a lot of times you have your one or two things you're really good at. And it's like, you know, really plug into those, because the more success you get, the better it is as you work on reducing those silos. And yeah, I thought about this presentation when I was thinking about how overwhelming the healthcare system and the change it is. Over Christmas break, I had the opportunity to go to Zion National Park and Bryce National Park in Utah. Beautiful places. When you read about them, they're beautiful because of just the structures and how the stone looks. But you know how that came about? It was the little drips of water that just kept pushing against the rock, and then a piece would fall off, and then it'd push again. And I thought, we're that little piece of water pushing the rock, and pretty soon we're all going to join in here. And I don't know what it's going to look like, but something's going to change because we're all working together, and we're all getting, even if we aren't all after the same initiative, if we're all trying to collaborate, identify gaps, not duplicate service, that's going to make a huge difference.
Yeah, Betty, do you know of any state health departments working on initiatives like this? No.
And I actually had an opportunity to talk with the College of Public Health at the University of Iowa, who they have a workforce initiative around, you know, age-friendly. And I think most of the federal grants now have a piece in that says, how are you addressing, you know, older populations? And I asked the person I was talking with, I said, so what are you seeing around the state in public health in terms of age friendly? And he said, there really isn't much happening. So there's real opportunity here. And again, I know I can already hear the groans of one more thing we have to do, but that's what I say, go back and look what you're already doing, and how can you plug in some of this framework into what you're already doing? Don't make it that you have to come up with these great and wonderful programs. You're all doing things already. Just maybe think outside the box about some of the things you're doing and look at that.
Yeah, that's a great reminder. Bailey put a plug in for the adult injury adult fall prevention at the University of Iowa Healthcare, I believe. Bailey, correct me if I'm wrong on the acronym there.
Nope, that is correct. Used to stand for hospitals and clinics. Now it's just healthcare.
Okay.
Yeah, that's a huge one. I can tell you from just working with older adults and talking with them about their health and what's going on. The number one thing is people are afraid of falling and getting hurt. That's their biggest thing, because most of the time they know if they fall, they're probably going to end up in long-term care and maybe not be able to function how they want to function. So yeah, that's huge, Bailey. So there, anybody who wants to get into injury prevention or fall prevention, you have your Bailey's your person. Anybody else have any thoughts or, you know, things you're doing or things you've thought about or never thought about?
Oh, Betty, thank you and your team for putting this all together. James Flores here in Des Moines. And I'm really identifying with you when you're saying that, you know, some of our traditional strategies and partners, they're just not going to be necessarily as innovative as, you know, these new innovations that are required and needed. We're going to have to look beyond some of our old partners, some of our old strategies. So here in Des Moines, I work with Riva. So it's not necessarily age related, But we are using some of the strategies that you're reflecting, specifically
Awesome.
that second point you talked about, that the patient based, the customer based. You know, it's very trendy right now. It's a real trendy slogan going around, meet people where they're at. Oh, it's so trendy to say this. And but how do you actually do that? And so I've been very fortunate enough to work with Knock and Drop Iowa, and they actually met their demographic at their base. They took a vaccine clinic to a Spanish word, mercado. It's just a basic market where these people are at. And we went out there and we had a great vaccine clinic. We shared some glucose and heart rate readings, especially as you're reflecting on those rural areas. Those are deserts out there, and they need so much support. So again, waiting in your office for people to come in is not going to work very much longer. That strategy is not going to work very much longer. We literally have to go out and meet people where they're at. I think we need to target this group as well. You had a little tone in your voice when you mentioned the social determinants of health. I'd love to hear you speak more on that. Thank you again so much for your insights.
Thank you. Thanks for sharing. Yes, and I agree. When I was at Public Health, we did vaccination clinics in crazy places, but we got people vaccinated. That's interesting. I had a different tone in my voice. When they talk about social determinants of health, again, as public health professionals, that's something we've looked at forever. And I think now traditional medicine is starting to realize that the 15 or 20 minutes they spend with them in the clinic or when they're in the hospital, that's not where their healthcare decisions are made. It's when they get home and when they're back in their community with what they're doing. And that's an area we've not connected very well. And I was a transitional health coach. So I called all of the discharges from the hospital to determine, did they understand their discharge instructions? I can probably say 1% of the people I talked to really knew what they're supposed to do when they got home. And most of them just made up their decisions. I said, did you fill your medications? Well, no, the pharmacy wasn't open and I don't know if I want to take this. And, so there's a big gap there between what's happening in their situations and what they're doing at home. And I think that's those social determinants of health that we have looked at forever. And now finally, we're maybe getting the whole health system to look at it. Looks like there's a couple things in the chat.
Yeah, Ronald has a great point. A lesson learned during COVID was reaching out to faith-based services to reach language
That's
barrier
great.
groups. I was on a call yesterday about financial literacy, and that was mentioned as well, that the faith-based groups are so strong, especially with the older adult population.
Yeah, that's a really good point because there is opportunity there. And I think, we already in public health have that prevention mindset. And so thinking about what sort of services can we offer that are going to work in that prevention mode, the vaccinations, looking at blood pressures, looking at, just how they're living spaces. What do they have access to? Just trying to prevent all of the things that are going to make them have an acute care, exacerbation or episode. Great dialogue. Thanks. It's always interesting to hear what you've been doing.
Oh, and Mary Kelly, thank you for sharing that. The YMCA has a dementia prevention program that helps 13 sites across Iowa.
Where is that, Mary? Where are you located?
That I'll put on my.
You kind of cut out there.
There you go. I was just trying to get on my video. I'm not sure why. Oh, okay. Hold on.
Oh, there you are.
It's held through the YMCA of Greater Des Moines. And, but we have 13 host sites across the state of Iowa. A couple local public healths like Johnson County has it. And Briarcliff University, we're going to be presenting at the public health conference about it. And we'll have a poster as well as a, sorry, I'm trying to fix my video, as well as a session. It's led by Dr. Quinlisk and so it is, we've expanded it and we're going to be expanding it to more sites. But the main hub is the Greater Des Moines YMCA.
That's awesome.
And
So
anybody
you
can
are-
contact me. I'm the project manager for that. So
So you are going to, it is an expandable program to other sites around the state?
it is. We piloted in 4 YMCAs in across Iowa, and then with Iowa HHS funding, last year we expanded it to about 13 different sites. And I know Story County is booming with they hold multiple sessions. It's a 10-week session. It's kind of like the fall prevention or diabetes self-management.
Yes.
It's really modeled around that with interactive sessions. So, and we're also doing a webinar series, and that will be posted on the website when we get that set up.
Thank you for sharing. That's awesome.
Yeah, that's great to know about. Well, we are almost reaching our time here. So unless anyone else
goodness.
has questions, just another plug for Betty, like she mentioned in her intro, but she is going to be at the public health conference in March. So come hear about her work specifically within a local public health agency there. Please do take the evaluation. I put it in the chat and I'll put it in there again. So before you leave, but Betty, I really just want to thank you for sharing your wisdom and knowledge with us. Your passion for the age-friendly healthcare really comes out in the way you present this. So, and thank you to you all for sharing your lunchtime with us.
Yeah. Thank you all for attending. It was good. Great.
Yeah. And so we do also have Lunch and Learn next month, March 21st, with Anne from Iowa HHS, and she's going to be joining us for a session called Beyond Ramps and Parking Spaces, Including People with Disabilities in Public Health Work. So make sure you join us for that. And as it was mentioned in the chat, we do record all of our Lunch and Learns on the Iowa Public Health Association YouTube channel. So you can find any of our past webinars on there that you may have missed, or if you want to revisit this one, it will be up shortly. And yeah, so take the evaluation link, stick on if you have any other questions for Betty. I'll be on for a few more minutes yet, so you can stay on and chat with us. But otherwise, thanks again for attending, and we'll see you next month.